Doctors don't know how to take care of themselves very well. We have one of the highest rates of depression and even suicide.
Suicide, yeah, sure.
And that to me is unacceptable. We represent health in the community. We should be the healthiest. We should be the example.
I do want to point out the shininess of your head.
I'm sorry. I'm in the stupid conference room in the ID.
It's the conference room. It's the lighting.
The lighting.
You look wonderful. Thank you. Lighting is perfect.
Exactly. I'm not like, made up for the news today. I'm just like, I ran here from the ER, so I apologize.
I think he looks fine. I do.
Thank you.
Well, ladies and gentlemen, that shiny head guy with the raspy voice is Dr. Suraj Saggar. I am Dr. Clenton Coleman. Welcome back to Recommended Daily Dose. We have a wonderful guest, Dr. Saray Stancic. She's a board certified physician with triple boards, right? So internal medicine, infectious disease, and lifestyle medicine. So we'll get an idea what lifestyle medicine is. She has a new book. It's called What's Missing from Medicine: 6 Lifestyle Changes to Overcome Chronic Illness, which offers a roadmap for optimizing all aspects of lifestyle to support personal health goals, longevity, and improve quality of life. She has another hat. She is a producer of a documentary called Code Blue that reveals the insufficiencies in the current state of medicine. So welcome to the show.
Thank you so much. I'm so happy to be with both of you today.
So we have a lot to talk about. I want to get an idea of what lifestyle medicine is and what made you go from, I understand why someone would go away from infectious disease since it's such a horrible specialty. But what made you go from infectious disease to lifestyle medicine?
No, actually, infectious disease is a great specialty, and we can talk a lot about that. But
I'm outnumbered.
Lifestyle medicine is a relatively new discipline. It is focused on educating and empowering patients on the importance of optimal nutrition, physical activity, stress management, effective sleep hygiene, the importance of addressing substance abuse issues like tobacco or too much alcohol, and then the importance of social interconnectedness. And the reason why this important discipline has become really very mainstream, and it's a movement that's growing across our country, is because we know the scientific literature tells us that when we address these aspects of lifestyle, we can prevent 80% of chronic disease, which I think is extraordinary. And it is largely why I've, after practicing medicine for 27 years and seeing so much pain and suffering that I know is largely preventable, I think it's important that as healthcare professionals, we speak to the importance of these. I think it's a incredibly valuable tool that remains latent in our doctors' bags, and I hope that it becomes much more prevalent in the way that we practice medicine.
It sounded like medicine started off like that, then we got away from it, right? The things that you talk about are what doctors are supposed to be doing. It doesn't sound like that's so far-fetched. Preventative medicine, stop from getting sick. I think we are.
What I like in your documentary, I believe, or you may have mentioned that we've gone from healthcare to sick care, and that really resonated with me because you're right. I think, and what Clinton is alluding to is that initially, you think about your old school family practitioners, you educate patients, but we become so fragmented and so super specialized that. Deals with the kidney, I deal with an infection. Everyone moves along in their little areas, and we're dealing bits and pieces of the patient. We've kind of gotten away from that holistic view. So, I that resonated with me, the whole idea that are we dealing with sick care, and why are we not spending more time? And I know we have a lot to talk about. I know that we should even get into why, as doctors, we're not being educated in med school. But I wonder if you could just take a step back and just kind of, how did you get to this transition from internal medicine? Disease, which we know is the best specialty, most cognitive specialty out there.
Of course.
Obviously, if you can't cut it, you become a nephrologist, like our friend on
of
the top.
Course.
How did I understand that there's some personal experiences you had that?
Well, I mean, sure. I mean, the obvious question is, how does an infectious disease physician evolve into, a passionate advocate of lifestyle medicine? And of course, it is embedded in not only my professional experience as a physician and witnessing so much pain and suffering that I now know is largely preventable, but also my personal story. I was in 1995 as a third-year medical resident. I was on call at Beth Israel Medical Center. It was a really crazy night. running from the ICU to the emergency room. And it wasn't until the mid-morning hour that I finally found that opportunity, where you can get back to the call room.
Sure.
I fell asleep right away. And then within 30 minutes, I was paged. And when I tried to get up, I couldn't feel my legs. It was that abrupt.
Wow.
Was brought to the emergency room, MRI, multiple sclerosis, multiple lesions in both my brain and spinal cord. And the neurologist tells me you'll probably be in a wheelchair within 10 years. So, it just took everything out of me. I had really worked hard to become a physician. It was my dream. I'm an immigrant to this country. I worked really hard to achieve it. And all of a sudden I arrived and it seemed like my life was over. And so I was immediately hospitalized, started on IV steroids to treat that acute exacerbation. And then the path that followed was starting a disease modifying therapy that had a significant side effect profile. And what I found was over the following years, my disease progressed and I was having 1 or 2 exacerbations a year, despite being compliant with the medications as prescribed. In 2003, about 8 years into the diagnosis, I was taking about a dozen drugs. And really just losing hope. And then by chance, and at this point I was chief of infectious diseases at the VA in New York. And by chance, I came across a publication that discussed the connection between diet and multiple sclerosis. And I was struck by this because I had never learned anything about diet in medical school.
Right.
And here I was a practicing attending physician and knew nothing. And so it was that publication that then triggered this interest in delving into the literature and trying to understand these connections. And it wasn't just, and there was the first article that I read was a publication in the New England Journal of Medicine in 1952. Roy Swank talked about saturated fat potentially playing a role in the pathogenesis of multiple sclerosis. But it wasn't just Swank, there were several publications that spoke to the importance of these connections. And so I went to my doctors who were, of course, the MS specialists in the country and expressed these, what I had seemingly uncovered, and they didn't think, of course, it was of any benefit. But I knew that the course on which I was, with very poor quality of life and dependent on, I had a pill box and I was 32 years old. It was not good. So
yeah, that was my question was, was there a resistance when you brought up the ideas of could you augment, disease modifying agents with lifestyle modifications, or did they kind of dismiss it at that time?
They dismissed it. They didn't think there was any value in it. So, despite that, I decided in 2003 that I would implement changes in my life, and I did. I changed my diet. I started to exercise. Believe it or not, in the 1990s, it was falsely believed that exercise worsened MS. So I was told not to exercise. So I was highly deconditioned. So I started out very slowly with a stationary bike and I could do a minute or two, but I'd get on every day and try to build. And over time, I got stronger and stronger. And, I brought my team together. Stress was very important. I wasn't going to take on that extra clinic time or that extra research project. And so I really, for the first time in my life, I put myself first. And, I responsibly was able to taper off of every one of those medications. And it didn't happen in a week and it didn't happen in a month, but I started to feel better. And that I went from a young woman who was dependent on a cane or set of crutches in 2003 to crossing the finish line at a marathon in 2010. And today, it's 25 years since my diagnosis, and I'm medication-free and disability-free. And of course, it is what fuels my wanting to share this, because there's nothing special about what I did. This is something that we can all do. And by the way, this is not alternative medicine. It's not complementary. It's not contra conventional medicine. This should travel together.
Right,
and of course, when people say to me, Dr. Stancic, are you against the pharmaceuticals? Absolutely not. I'm an infectious disease physician. Medications are an important part of our armamentarium. But if we know that the many chronic diseases that we see today in clinical practice are largely preventable because they're largely lifestyle related diseases like heart disease and diabetes and obesity, and even there's ample evidence that Alzheimer's disease, if we know this, then prevention is preferable to cure. I'm sure you would both agree. So I think it's important that we place emphasis on this.
So that's your journey. now is lifestyle medicine, is that now something that just for physicians out there, is that something you can be boarded in now? How
Can
are
be
there
boarded.
residencies or fellowships in lifestyle and preventive medicine?
It is, yes. The first board certification class was in 2017, and I was in that class. There are now residencies that are being built at many institutions. But in large part, it's common sense, and it's regrettable because the principles of lifestyle medicine really should be embedded in the foundation of the medical education model.
Sure,
I mean, the curricula should. When we were in medical school, Clenton, if you went to New Jersey Medical School, I took a preventive medicine course. I don't know if they had that when you were there.
It was an elective.
Oh, okay. Well, for us,
it was preventive medicine and statistics or epidemiology or something. It wasn't like.
It wasn't a core tenet. Probably wasn't a core tenet, right, of your education.
Yeah, I think the education as far as the lifestyle and preventive care is pretty poor in medical school. It's all about the pathophysiology and
yeah. Well,
treating.
I mean, when we took preventive medicine, it was really focused on seatbelts, mammograms, and colonoscopies. Mammograms and colonoscopies they're secondary prevention, right? The idea of primary prevention is to prevent the disease from ever occurring. And there was no discussion on that. And the way that we prevent diseases are by these lifestyle factors. I mean, even heart disease and diabetes, there's ample evidence in literature, but even things that people may not think about, cancer, about a third of malignancies could be prevented.
You're right.
And we're not placing any emphasis on that. And I think that needs to change because the cost of healthcare in this country continues to grow. I think we're at $3.6 trillion per year. And about 86% of the money that we spend is spent on chronic diseases that we now know are largely preventable.
Oh, sure. I saw a segment of the documentary you produced, and I think there was a segment where they're interviewing a medical student, and he was saying when he learned about hypertension, he memorized 15 meds that he would use, different classes of meds. And obviously Clinton would tell you the same thing, but he said we never really approached the idea of talking to a patient about their diet and changing to a plant-based diet, decreasing sodium. I mean, these are things that you think about secondarily, but the kind of primary focus in medical school is about pharmacotherapy. Obviously, as an ID doc, I'm not anti-pharma as well, but I find that very interesting that it seems to need to be starting, much earlier on and not an elective. It should be part of the core education that we receive.
For sure, it should be the foundation. Medical school is built on the idea of pathogenesis, right? We learn the disease state. Right. And so I tell my medical students, we become really good disease detectives, right? With the art of history taking, we order imaging studies and blood work, and ultimately we're collecting these clues to make the diagnosis. And once we have that diagnosis, we manage our patients. Our assessment and plan includes a pharmaceutical agent, or a surgical intervention, or a procedure of some sort. And all of that is important. That pathogenesis is part of the human health continuum, and it should be part of what we learn in medical school. But what we don't learn is the opposite of pathogenesis, and that's a term called salutogenesis. Salutogenesis means the study of health and well-being. How do we maintain health and well-being? And that would include curricula modules on nutrition and exercise and sleep and stress management. Doctors don't know how to take care of themselves very well. We have one of the highest rates of depression and even suicide.
Yeah, sure.
And that to me is unacceptable. We represent health in the community. We should be the healthiest. We should be the example.
As an example, Clinton, I know there's a vascular surgeon we used to see all the time who was an excellent surgeon, but smoking nonstop, walking around, which made no sense. And, again, you would see some physicians that are morbidly obese, but obviously there could be many factors for that. But, and one of them maybe they were just working too hard, or they couldn't have time to exercise. So I agree. We oftentimes are not the examples that we should be for our patients. But I was wondering,
let me make a point before you move on.
Go ahead.
And we talked about the healthcare providers, but I think it's so inundated in the delivery of medicine on all aspects that patients are so focused on treatments and medications and diagnostic and therapeutics that, if they're shocked if you tell them to eat better or eat less processed foods or exercise. That may not solve, but alleviate some of your symptoms. Or, God forbid, there's a tea that you can drink, hibiscus tea, that was studied alongside a blood pressure medication, captopril, and is equally effective at reducing your blood pressure or lowering your salt intake. So I think patients even expect medications because we pushed it so much that once
They'll feel
you
cheated if you don't give them medication. They'll say, "Why am I paying this copay?" It's the same idea with coming to the doctor saying you don't need an antibiotic. You know, they want a medication, right?
Right. I need a Z pack because someone else gave me a Z pack. So I think it's the spiral that we're in. How do you think we get out of that, though?
I think it's education, right? It's about shifting the paradigm, because what you just mentioned, overprescribing of antibiotics. I remember when I was an ID fellow, half of my job was trying to get the surgeons to stop writing for these broad spectrum antibiotics, and we have reaped the benefit of all of that, right? The benefit. We have multi-drug resistant organisms. We saw C. diff rates skyrocket, and the complications of our actions. So sometimes our actions are not popular, but as leaders in healthcare, I think we have to stand up and do the right thing, and we have to educate our patient population. Obviously, you're not going to write for that Z-Pack when you know it's a viral upper respiratory infection. Or, I want to mention one thing. I know that as an infectious disease physician, you have been first and forefront in battling this COVID-19 pandemic, and I just want to thank you for all the important work that you've done. And I've seen how much you've done to educate the public. But I just want for a moment to connect these dots between this acute infectious contagion, this pandemic with which we're dealing with today, and the backdrop in this country of the chronic disease epidemic. And this, that we have seen the highest morbidity and mortality in those that are living with a chronic disease that are then infected with SARS-CoV-2. And in fact, very early on in the morbidity and mortality report, I think it was June 2020, where we were told that if you had a chronic disease at the time you were infected, you were 6 times more likely to be hospitalized and 12 times more likely to die.
Wow.
So it's interesting to me how these two have really come together. And I pray that the one of the silver linings of this difficult year that we've experienced is that we might awaken to the need for us to get healthier as a country, that we need to make better decisions, because this disease has really, this COVID-19 has really shown us how vulnerable we are.
Yeah, Clinton and I talk about time. It's highlighted our problems with obesity in this country, with our incidence of chronic diseases, as well as other socioeconomic issues, right? The disproportionate effect on the lower socioeconomic status, the Latinx, African-American communities. So there's so many things this has brought to light. And so we never would have ever wanted to go through this. And obviously we're still going through it, especially in other parts of the world, very severely. If we can find any light or any goodness out of this, it would be that, is to, lend light and awareness to those issues. And then, as you alluded to, and then of course, make a change, it's beneficial going down the road.
Agreed.
Yeah, but I wonder if you could dive in a little bit more about, I know you outlined for lifestyle medicine kind of 6 different tenets or points. Can you just dive into them each a little bit? And then actually, maybe Clinton and I can see how we can not even utilize that in our own practice, maybe utilize it in ourselves. I know you mentioned one. I'll start off with sleep. And I realized, man, my sleep hygiene is terrible,
Oh, we have to fix that.
And I realized it, and I think this is something that people have been saying, throughout the year, even if they haven't been directly affected by COVID, working from home, the stress, the anxiety, looking at social media all night long, scrolling through their phones. I think it's affecting a lot of people. And, we have colleagues that are sleep medicine docs that are telling me they're booked 4 or 5 months straight now because of all the insomnia and other sleep issues. So I was wondering if you could just kind of spend a few minutes with.
So sleep is a huge issue that we tend to not give a lot of attention to. I think those of us in lifestyle medicine tend to spend a little bit more time on the food and the exercise, which is of course important, but the sleep is incredibly important. About a third of Americans don't sleep very well, and then many of us are dependent on hypnotic agents or benzodiazepines to get to sleep, and then alcohol is also a problem. So really characterizing and understanding, it's about taking a really thorough history with a patient, understanding what they're doing, because if you're drinking coffee at 3 o'clock in the afternoon, it's going to affect your sleep cycle. What are you doing in the pre-sleep, as a pre-sleep ritual? Are you staring at your phone and that blue light is hitting your retinal ganglion cells, and then it's rather blocking release of melatonin at the level of the pineal? So it's really about understanding in totality what that patient's routine is like, and you can identify reasons why they're not sleeping effectively. And then it's about, I think it's also about environment, right? Cool, dark, and quiet. You want your room to be dark. So like blackout shades, you want it to be cooler. And obviously you want it to be a quiet environment. And then schedule is important. I think people are very erratic with their schedule. You have to really fix your go to bed time and your wake up time, and there should be 8 hours between those two numbers. If you do that,
you change on the weekends, right? So I shouldn't sleep on the weekends, that type of thing.
You shouldn't sleep in.
No.
My dog's barking at 7 o'clock in the morning or 6:30 in the morning.
Okay, so he's trying to make sure you keep on your good sleep schedule.
Right. I can't sleep in if I wanted to, so.
And then extra, and the funny thing is, I mean, I use the analogy of a wheel, and the 6 aspects of the spokes on the wheel. And the reason I do that is because to give that, so that the individual can envision, it's important that you address all spokes simultaneously, right? Because as I said, some of us are really good at exercise, but then we drink too much or we don't sleep effectively. So the sweet spot is when you address all aspects. That's when you're going to achieve your best self. That's when you're going to reduce your likelihood of developing a chronic disease. And the hope, of course, is for each and every one of us to age gracefully, so that at the end of life, on that last day on planet Earth, we can enjoy a lovely day with those that we love, and then we go to bed and we pass away peacefully with dignity. And it doesn't have to be, that bookend in the ICU of suffering in the ICU or in the nursing home. And I know you both know this, as you in clinical practice, this is what you witness every day. These are the consults that you get. I mean, I remember as an infectious disease physician at the VA, a common consult I would see was an infected diabetic foot ulcer, an osteomyelitis case. And, we put these guys on the right antibiotics and we debride them effectively. And sometimes they don't get better. Amputation. So now you have a poorly controlled diabetic, status post amputation. They're not going to sign up for a 5K. They're going to become more sedentary, blood sugars further out of control, blood pressure, and then a stroke. And now we're being called in as the IDs Act to address
the pneumonia, right? Then and now they have chronic, their renal insufficiency, and now someone is going to dialyze them. It's just going on and on and on. No, it becomes depressing. And when you talk about chronic illnesses, I mean, ID and nephrology are seeing this all the time.
Of course. I'm sure you both work together closely on these patients. But what's striking with all of that said, and diabetes, of course, is a disease that is exploding in our country. When I was in medical school, we were about 2%. Now we're at 10%. And the CDC predicts that by 2050, we'll be at 30% of the American population will be diabetic. Our healthcare system cannot support that. And yet the literature tells us that we could prevent 93% of diabetes.
Right.
We know how to do that now.
Sure.
So we should be screaming from mountaintops. This should be the leading story on every news, opening story. We know how to prevent diabetes. It should be on the cover of every magazine, every newspaper. I mean, these are messages that need to be conveyed to the American public.
It's literally a cure. And I think we don't paint it as that, right? Some people think that things that they do with their diet or their lifestyle that has negative impacts on their health, those things can't be reversed because we've been inundated with it's genetic and all of this. People can go into diabetes, they can come out of diabetes. So can you, without giving away the sauce, can you highlight the other 5 lifestyle
Sure. So nutrition,
switches?
So nutrition, we should be consuming a diet that is rich in plant-based foods, right? And that's because of the fiber content and the phytonutrients and the antioxidants that are incredibly important in maintaining cellular health. Doesn't mean you have to.
Can I ask you, do you recommend being a vegetarian or vegan? I mean, I'm a pescatarian. Clinton eats everything under the sun. So I've tried to work on his diet with him a little bit.
I had a hot dog for lunch after.
It's a work in progress, but
I think
we talk a lot of different people on the show. Some will say you absolutely have to be vegetarian. Some will say, no, you need to be vegan. Some will say, no, you can eat meat, but you have to, take the focus on the American diet where protein is the main percentage on the plate, and make that a small percentage and include more vegetables and fruits.
But if you were listening, she said plant-based, right? So
plant-based. So strictly speaking, if you look at my diet, I don't eat any animal sources. So I guess I would be, by definition, a vegan, but not really because, vegans can be very unhealthy. You could eat a lot of processed junk.
Right.
And I just want to make one point that I think is important. When you said protein, because I think immediately when we say protein, we think animal sources.
Sorry. Yeah.
But plants have plenty of protein and have all the amino acids that you need. So if you, and I'm not saying that you need to be vegan or fully 100% plant-based. This is the diet that I've adopted because it's what I feel best at. But in our country, the animal is always the center of the plate. Like if you ask Clenton, what did you eat for dinner last night? He's probably going to say I had chicken, or he doesn't say I had the sweet potato or the broccoli. We
Sure,
tend
that's
to,
always the side, yeah.
that's the side dish. And what we need to do is move from the vegetable being the side dish to being the main event. And if you're going to have any animal sources on your plate, that they should be the minority. Because, when you eat a plant-based diet rich in fiber, you're going to then change the makeup of your microbiome. And that could be a whole conversation, but the microbiome is incredibly important. And I know you know about that as an infectious disease doc. When we eat a fiber-rich diet, we enrich the good bugs, and then the good bugs produce good signals that then serve the betterment of the individual. And there's a lot of literature now in the MS space looking at plant-based diets, changing the microbiome to favor these organisms that then produce these chemicals that interact with the immune system.
I'll just interrupt for a second. The microbiome, of course, we should talk about some other time, but it's being looked at for a whole host of inflammatory and autoimmune disorders, even IBDs, ulcerative colitis, Crohn's disease. They're even looking at things like autism spectrum disorders, so a whole host of neurological,
diabetes,
the gut-brain axis. Yeah, so it's actually a fascinating new area of medicine beyond just replenishing the gut flora to prevent C. diff. It goes beyond that. So
much beyond that. Yeah. And then exercise, Clinton, you asked me to speak on the other exercise, of course, is important. We should be engaging in 115 minutes at least of cardiovascular activity a week. Doesn't mean you stop there, you can go further. And you should be engaging in some strength training at least twice a week as well. So really, it's about trying to encourage movement. And particularly this year with COVID, we've been so sedentary.
Yes.
There was a recent publication that I think the average American has gained like 20 plus pounds this year because of this.
They call it like the COVID-15, like they say the freshman.
Quarantine 15, yeah.
It's not even the COVID-15 anymore. It's like the COVID-20 something.
Okay.
Yeah, it's bad. And stress is incredibly important. And you both have had a very stressful year, I'm sure. So I think it's important for us to practice some self-care and mindfulness and some quiet time, and carving time out of our busy schedules is incredibly important to ensure that we're addressing our personal needs. Sleep, we talked about. Interconnectedness, there's a lot of data looking at the importance of, we know that folks that are depressed or isolated are more likely to develop a chronic disease and die prematurely. Right. There was important work done by two social scientists, Christakis and Fowler, who looked at the Framingham Heart Study data, and they found that, it's interesting, our friendships, our connections, they're almost infectious. If you are obese, your friend is 57% more likely to be obese because, and that makes sense, right? Because our friends, what we do with our friends,
perhaps, right?
Yeah.
If you have a friend that loves to hike, that's very different than the friend who likes to drink beer and eat cheeseburgers. You can see how you might engage in bad behaviors.
And I think with the pandemic, obviously, people are not as socially interactive and connected as they have been. But even before that, people may be more connected through social media, but they're actually reporting, I talk to people, even patients, that they're actually more alone. They're spending less time in person or on the phone and more time, on social media.
I'm not a big fan of social media, and I'm not a big fan of phones. I'm always amazed by, like, I'll go to the beach and on this beautiful day and I see people looking at their phone. They're on the beach and they're looking at their phone. I think it's done probably more damage than good. And we have to become very mindful about the hours that we're spending staring at our phones and looking at Facebook and Instagram, and we're missing out on the real opportunities to connect. And that means being ideally in a room with a person and exchanging thoughts and ideas. And I know it's been hard because of COVID, but hopefully we're on the other end of this thing and we could start connecting again on a very human level.
I wanted to ask for patients, how does lifestyle and preventive medicine fit in? I mean, is it something where they would go to their primary and then would see a lifestyle preventive medicine physician? Is it a combination? Do you work in concert with other primary care doctors, or how do you see patients, or what is the role, directly? Are you more like advising primary care doctors, or?
Yeah, so I mean, early on, I'm not practicing right now because I just took on a new position as chief medical officer for an organization that's trying to bring this across the country, and so I'm excited about that. But when I was practicing medicine in Ramsey, I was acting more as a consultant. But I don't think this should be a consultant. This role should be sort of part of the primary care experience, right? It should be built into that. We're
Right.
not there yet. But I think, there, as I said, there's a movement in that direction. I teach at the medical school these concepts of lifestyle medicine because I know they're not getting it in the curricula right now. So the American College of Lifestyle Medicine has built these interest groups across the country. I think we have 50 medical schools that now have it as part of their curricula, and I think we have 170 medical schools, so we still have work to do. I would love both of you to attend the American College of Lifestyle Medicine conference. It occurs every November. This year it's going to be in Dallas. I think it's an important annual conference that, and I've been so happy to see that every year attendance grows. I think the first year that I attended might have been 200 physicians. Last time we met together before COVID, we had about 3,000 physicians. And on that occasion, I screened Code Blue, our documentary, which was really awesome. And so, it's definitely a movement that's growing in the right direction.
How did you get involved? I know you're the producer, but just, I know Clinton has dreams of making a movie one day about.
Clinton, we're going to make a movie together.
But he wants to make a movie about like a superhero Nephron or something very odd. But
okay. Well, we could put a cape on him.
No, how did you get involved as a producer? That's very fascinating. Yeah. Certainly.
Well, yeah, I mean, part of it was somebody came to me and said, your story's pretty remarkable. Because again, if you knew me, I used to walk with a cane and I was very debilitated. And if you know me today, I run every day. So that story, that arc is something that we wanted to share. But for me, the film was really about shedding light on the lapse in medical education and in healthcare, right? Because the dream of the documentarian is to create a buzz and a level of interest so that it leads to meaningful change, right? So for me, the win would be to assure that moving forward, that the curricula changes to reflect these all important principles in lifestyle medicine. So, we came together, a group of 5 women, and we were going to make this film, and it took us nearly 5 years to make it. We just traveled across the country with a camera and we told stories, and some of my patients are featured in the film. A young woman that came to see me with multiple sclerosis about 6 or 7 years ago, newly diagnosed. As you know, MS is largely a disease that is primarily diagnosed in young women. I was 28 years old when I was diagnosed, and she came to me crying because she had just been diagnosed, and I looked at her and I said, well, what about the fact that you are obese and you're hypertensive and you're pre-diabetic? And no one, here's what is upsetting to me is that, as you said, as specialists, we just treat whatever it is that we specialize in. So this young lady went to see a wonderful MS doctor, and the MS doctor recommended the disease modifying therapy, but he didn't address the fact that she was obese and pre-diabetic and hypertensive. And we know the literature tells us that these are all risk factors for MS. And they're also indicators of poor outcomes for MS. So anyway, this young woman lost, with my care and my support, she lost 90 pounds. She reversed her pre-diabetic state. She's no longer on the 3 antihypertensives that she started out with. And she's vibrant, and she's not even taking a disease modifying therapy because she feels so well. She's being followed very closely by her MS doctor. But these are all missed opportunities, right? So for each and every one of us. So imagine if Dr. Coleman, this amazing nephrologist, began to talk about the importance of aspects of lifestyle. I mean, I think it would be really, really meaningful.
Yeah, I think, we fall into the trap of, one of the common risks for kidney disease is diabetes and high blood pressure. And then, we have this tunnel vision when I'm seeing someone for kidney disease, and I'm saying your diabetes needs to be better controlled. Move on. That's the thing. We have this tunnel vision in medicine. I think it's just this subspecialty, super specialty, and
Yeah.
You don't see the entire picture, and everything's turfed to someone else.
Yeah, but yeah, it goes back to how we started. I think it's a good way to end it, is just the idea that, healthcare is sometimes just sick care. And even the way doctors are reimbursed, or how, it's just time spent with a patient, but just time educating oftentimes is not considered, valuable time. And patients oftentimes, like you said, expect a medication, a drug, an antihypertensive, an antibiotic, and they don't realize that just that education component could be much more valuable. Can you tell us, I know you said you may not be all social media, but I'm sure, with producing a movie, a documentary, a new book coming out, how could people find you online?
So my website is drstancic.com, and then I'm on Instagram, Facebook, and Twitter. But drstancic.com will take you to both the film and the book. And codebluedoc.com is the website for the film. And we released the film about a year ago. We had planned a tour across the country, but of course, because of COVID, we had to postpone that. But hopefully, we'll get back out there soon.
I saw your website, I saw the trailer. I'm looking forward to watching the actual documentary. So first of all, the website is very nice and very well done, but I look forward to watching the documentary, and I hope that you can take it on the road, because not just, for your own self, but really just to educate us. For us, it was a great education today. So I want to thank you so much for coming on.
I have one last question.
For me,
if there's a lifestyle cure for taco meat, can you see, right? You know what taco meat is?
No.
It's when your chest hairs are poking out of your shirt.
Oh my goodness, what are you talking about? He likes to make fun of me. So he always has to.
Is there a preventive treatment for that?
Listen, I had to take the tie off. It was a long day.
Gosh, you guys were
Real
so
long day.
I only regret this wasn't in person. I would have loved to have been in the same room with the two of you.
Well, we used to do it in person.
I'm coming back when we can do it in person.
That's right.
Definitely.
It becomes a bit irreverent, but
So where can we get the book? Is it out yet?
It's everywhere. Is it Barnes and Noble, Amazon?
Okay. Oh, excuse me. Wow. All right. So what to plug that?
Yeah, please do. I'm really proud of the book. I please read it. I want you to read it. And it was a labor of love, and it's getting out there, and it's serving the purpose to stimulate people to create change in their lives, because we want people to live happy, healthy existence and live to their optimal potential and be joyful doing it.
Well, I tell you, your passion for shows very strongly, and we look forward to hearing more from you, and for hopefully this revolution in the way doctors are educated and the way we think about medicine, think about disease. So we really want to thank you again so much for taking time out of your busy schedule to come on to our show, Recommended Daily Dose. I am Dr. Suraj Saggar with my sidekick, or is he co-host? I guess sidekick, but I'm co-host, Dr. Clinton Coleman. We hope everyone out there will rate, review, and subscribe. Until next time, we want everyone to be well.